In continuation of the vascular disorders, the next part is about the Raynauds phenomena or Raynauds disease. That word Raynaud phenomena and Raynauds disease, these are having a different connotations. Raynauds phenomena is a condition where there is a spasm of the blood vessel, arteries particularly. As a result of the spasm, there will be signs of ischemia. Now, the Raynaud's disease is again a primary Raynaud's disease and secondary Raynaud's disease is considered. The primary is when there are no other associated illness, but the patient is presented with the spasm only. Whereas secondary Raynaud's phenomena is when it is produced as a complication or maybe coexistence of other disorders like collagen vascular disorders, or either it could be due to induced due to the medicines or such conditions where there is a other alternative causes for that. Now, the criteria for diagnosis of primary Raynaud's phenomena is when the patient has episodes of pain or claudication like pain or symptoms of the ischemia when they are exposed to either cold or stress, either exposure to the cold or stress like vibrating instruments like drills, etc., or even driving vehicle. Such activities producing the episodes of spasm of vessels with the signs of ischemia are the characteristic of the primary Raynaud's disease. Characteristically, the primary Raynaud's disease is presented with the bilateral involvement, symmetrical, and generally it doesn't result in gangrenous changes. There will be episodes of ischemia which get relieved as the patient takes rest, and gradually there could be slight changes in the tissues, that chronic ischemic changes which we have discussed earlier, that like the skin changes, adipose tissue being reduced, or even muscles being atrophied, they may occur, but necrosis or gangrene generally doesn't occur. Then there are no other identifiable causes as such. If you do the examination of the capillary circulation remains normal, it's not affected. It's only the arteries, the major arteries which tend to get these middle or the middle order arteries which they go into spasm temporarily, and hence if you go for the capillary examination would be normal, and there will be no signs of other inflammation in the patients, and if you do the investigations, the ANA test would be negative in case of the Raynaud's phenomena. Primary Raynaud's phenomena, whereas secondary Raynaud's phenomena can occur due to many causes as such. Either there could be abnormalities related to the constitution of the blood, hematologic conditions like disseminated vascular sclerosis or thrombocytosis, etc., or collagen vascular disorder like autoimmune disorders, and among them systemic sclerosis, SLE, is the most common cause for that. About 90% of the patients of secondary Raynaud's phenomena would have SLE as the basic cause as such. And the other causes could be like drugs. Among the drugs which can induce these are the methotrexate is one of the well-known oldest of the drug which was used in obstetric practice earlier, even now occasionally used. And that drug was known to produce the ergot alkaloids. The methotrexate is an ergot alkaloid. Earlier, ergot as such was being used as such in the obstetric practice, and at that time that vasospasm produced due to that would be quite high. Now these days the ergot is not used, methotrexate is rarely used, and you have other options also now in obstetric practice. But that was one of the common drug which was used, which induced these Raynaud's phenomena, second Raynaud's phenomena. Other drugs like bleomycin, beta blockers, or even immunotherapy in treatment of tumors pathology, these are known. And the other diseases like pheochromocytoma, malignancy also is known to occur. Now, as far as the secondary causes are concerned, now in 2005, from onwards, the causes are categorized into vascular, neural, and intravascular abnormalities. Vascular are where there is a abnormality related to the blood vessels, as such blood vessels condition, inflamed, the mucosa becomes inflamed, as in case of the systemic sclerosis. Neural, where the nerves are abnormal, there is abnormality of the nervous system and hence there is a spasm. Or intravascular, where it could be related to the hematological conditions as such. The other exact causes of the secondary Raynaud phenomena, which are absolutely listed as such, are the progressive, among the autoimmune disorders, progressive systemic sclerosis or scleroderma, which was known as CREST syndrome earlier. SLE, as I told you, the 90% of the conditions is SLE. Other connective tissue disorders which may overlap the other symptoms and dermatomyositis, polymyositis, rheumatoid arthritis, Sjogren's syndrome, vasculitis, primary pulmonary hypertension, environmental factors like vibration injury, vinyl chloride exposure, frostbite, lead exposure, arsenic exposure, organic solvent like xylenes, or infectious syndromes like hepatitis B and C, microvascular infections, and neoplastic syndromes like lymphoma, leukemia, myeloma, etc. So when a patient presents with this Raynaud's phenomena, it's quite important to study the whole condition, identify the possible underlying cause and confirm whether it is primary or secondary. In case of the secondary Raynaud phenomena, all your approach will be to treat that primary underlying causes, and in the primary Raynaud phenomena, whatever we discuss would be relevant. The other causes of the secondary Raynaud phenomena are metabolic pathologies like acromegaly, myxedema, diabetes also can induce the same pheochromocytoma, and hematological conditions like paroxysmal nocturnal hemoglobinuria, polycythemia, cryofibrinogenemia, drugs as in case, as I told you, ergot-alkaloids, oral contraceptives, bromocriptine, beta-adrenergic blocking drugs, anti-neoplastic drugs like zinc alkaloids, cyclosporin, and so on. So lots of causes can be there. Now, in all that conditions, the primary, particularly we will be focusing on the primary Raynaud phenomena. Secondary Raynaud phenomena, there is no need of specific treatment for the Raynaud, and whatever we now consider are not so much relevant. Of course, partially they are relevant too. The other causes like vascular abnormalities are a deficiency of vasodilatory mediators. Now, in the normal circulation or normal physiology, the blood vessels, they are allowed to get dilated or contracted depending upon the need of the tissue. Arteries may go into contraction or dilatation to maintain the to have that physiological homeostatic mechanism of maintaining the circulatory pressure as well as maintaining a proper oxygenation of the peripheral tissues or perfusion of the peripheral tissues, and these are mediated by various substances in the body, including nitric oxide. Nitric oxide is one of the important substance which helps in the maintenance of the blood vessels in a dilated condition, and in Raynaud's disease it is now known that nitric oxide in the blood vascular compartment would be lesser. In addition to that, other factors also could be producing the same, and the other identified substance now is endothelin is as a constrictor found in the endothelium, and this is now identified as one of the causes of the Raynaud's phenomena in secondary Raynaud's conditions. Neural abnormalities are, as per the newer theory, now this is a new theory, it's proposed as the primary Raynaud's involves an abnormal function of the brainstem areas that integrated cardiovascular compartment. This is one of the recent theory which has come up, and then it has resulted in the prescription of some stress relieving drugs in the treatment of Raynaud's disease. Intravascular abnormalities like primary Raynaud's disease, the systemic sclerosis, where there will be activation and aggregation of the platelets are seen. Increased production of platelet thromboxane, which is also one of the other causes in the Raynaud's phenomena. And systemic sclerosis, a fibrolytic system has been reported. So now the issue is the various molecular abnormalities are now identified, and oxidative stress also is known to be a cause for that. Then as far as the etiology and epidemiology is concerned, primary Raynaud phenomenon occurs more frequently in women than in men. The prevalence will vary from ranging from 4.9% to 20.1% and in women it's 3.8 to 13.5% in men in the average compared to the population. Then primary renal phenomena usually occurs in the second or third decade of life, that's 20th or 30th years, the 20 to 30, that's the common age group where the lesions tend to occur. And the secondary phenomena can occur at only at any age depending upon the existing previous disorders. Then patients with the Raynaud's phenomena usually present with that episodes of vasospasm in cold temperatures, or when there is emotional stress. The patient would have the typical symptoms of ischemia either in cold seasons, or when the patient is exposed to cold temperature due to any reason, or when the patient has episodes of stress as such. And usually it affects the terminal parts of the fingers or toes, or nose or ears or nipples or lips. These are the areas which are involved frequently, and the proximal part of the body is generally not involved. And maybe in advanced conditions the proximal part could be involved. It's only the tips of fingers, tips of toes, nipples, ears or nose. These are the areas which are often involved. And there could be at least either there could be a pallor or bluish cyanosis or hyperemia depending upon the stage of the spasm. When you examine, immediately after the spasm there will be hyperemia, and after a certain period of time there could be cyanosis, and later on it can result in a pallor. So any of these changes could occur. The typical presentation of Raynaud's phenomenon during the attacks would be like either there could be pallor or there could be bluish cyanotic changes which could be seen, and or it could be a dark blue also. Color may change during the course as such. Initially it could be pallor, then cyanosis, and then hyperemia, or the other way changes could occur. Some of the patients in such conditions, one of the methods of identifying a latent phenomena would be the cold stimulation test, where the patient initially, the patient's limb is kept in a cold water, or it's even as in the cold water area, dipped in cold water for 2 minutes, and then or initially it could be in the hot water, warm water, and in the warm water the color would be actually normal, or maybe slightly there would be a fresh color. The moment the limb is kept in a cold water, the next initially it is hot and cold test. Adson's have hot and cold test, where initially the limb is kept in a hot water and then it is exposed to the cold water, and immediately after keeping that in the cold water there will be color changes. The latent color changes can be observed better by that hot and cold stimulation test or challenging test. The other methods also could be used by using an ice cube over the body. When you keep an ice cube over the body, at that area there will be a mark, these changes of ischemia at that area, showing that typical marking of the ice cube placed over that. These are the standard clinical tests done. For the primary Raynaud phenomena, there is no other confirmatory tests as such. It has to be made out by the clinical diagnosis of signs of ischemia. Signs of ischemia we have already discussed. As far as the treatment is concerned, there is no definite curative treatment for the Raynaud's primary Raynaud's phenomena. But primarily it's about lifestyle measures where you avoid the use of either these exposure to the cold or compression of the limb, like gloves, avoiding the use of gloves also. Many of the patients may have episodes of pain when they use a glove, and that can be avoided, or such even stockings can be avoided, or exposure to the cold has to be avoided, and stress, wherever possible the stress has to be reduced. The other options of the treatment which are often used as among the drugs, calcium channel blocker drugs like nifedipine, which is used as an antihypertensive. Application of nitroglycerin ointment also is one of the options. The other drugs which are often used are phosphodiesterase enzyme inhibitors like sildenafil or tadalafil. Sildenafil is more frequently used as such, or rarely botulinum toxin also could be injected. Secondary renal splenomegaly, as we have told, it requires a specific treatment. As far as Ayurvedic treatment protocol is concerned, we have treated a good number of patients of Raynaud's disease with the Kaishoragukulu Mrityunjaya Manjistalic given internally, and Agnitikis and Manjistalic Sharavasti as a supplementary course as such. In patients who have a lot of stress, a Smithsagar Rasa also could be prescribed as a treatment. That's one of the conditions. The next part which we discuss would be non-coronary atherosclerosis. Atherosclerosis is a common condition. Coronary atherosclerosis we have discussed earlier when we discussed about the cardiac pathologies in the Raktavaha sources. So I would be limiting to non-coronary atherosclerosis in the present discussion. The term atherosclerosis is originating from the Greek word like athero, which means gruel or wax. So it's suggestive of the nature of the lesion, which is wax-like, and it corresponds to the area where there could be the changes of atheroma or atherosis would occur. But once that kind of a degenerative change occurs and it becomes gruel-like, it becomes fibrous later on and hardened, and that hardened fibrotic area is the sclerosis. The sclerosis is related to hardening or induration. So atherosclerosis is suggestive of a disease process where there is initially a degenerative change and the structure's membrane becomes wax-like. Then it progresses into a hardened button-like structure, or a plaque is formed in the vessels as such. Now, depending upon the stage in which you have seen and the types, they are categorized into 6 types. Atherosclerosis is categorized into 6 types, like adaptive intimal thickening, the initial stage. Type 2 is fatty streaks. Type 3 is transitional or intermediate lesions. Type 4 is atheroma, and there is a spelling typing error. Type 5 is fibroatheroma, where there is a fibrous changes occur. And type 6 is a complicated plaques with the surface defects, where either there could be hematoma or so on. Now the same, whatever I have suggested, to make it clarified, like what is meant by these types is initially in the first stage there will be initial lesion where suppose if you take a biopsy, the biopsy would be normal, but there could be slight changes in the mucous membrane, the endothelial membrane, where you may see that there could be slight deposition of the atheroma. The areas may be somewhat thinned out. Surface would be, the intima could become having that layer of atheroma. A normal this vessel, compared to this picture is depicting the changes, like on the other side you can see the normal configuration of the vessels, tunica intima, tunica media and tunica externa. In the initial stages, the tunica intima becomes thickened, where there could be they could be seen only in the histological appearance, where there could be infiltration of macrophages as such. Otherwise, clinically it will be normal, or even other examinations, investigations, they may show normality. The type 2 is where there would be fatty streaks, like where there could be yellowish discoloration below the area of that atheroma's deposition, and this is gradually results in narrowing of the lumen of the vessels. The third type is the intermediate lesion, where there will be even the lipid pools, the fatty layer will become more, and the lumen becomes further narrowed. So that's the typical feature which occurs in the type 3. And type 3 is that stage where the patient may have the clinical symptoms presented. In the initial type 1 and type 2, there will be no clinical presentation symptoms seen. Only when you go for a thorough investigation, you may identify them, but otherwise it may not be identifiable. Type 3, of course, the patient may start having the clinical symptoms of atherosclerosis, where there would be consequences of the either inelasticity of the blood vessel as well as narrowing of the blood vessel. Both these factors, because of the deposition of the fat, the arteries become less elastic, and when they become less elastic, the circulatory pressure increases, systolic pressure increases, diastolic pressure would be again increased, and the pulse pressure becomes lesser and lesser. The range of that pulse pressure, the difference between the systolic and the diastolic pressure, gradually diminishes, and at the same time the lumen acid is narrowed. That also adds to the circulatory pressure being increased. The blood pressure tends to become increased. The clinically, when you start palpating the vessel, you may feel the arteries may be somewhat rigid as such, but stage type 4 onwards, the vessels are palpated like cord-like, thickened as such, where there is a huge collection of the fat tissue, as well as there is a tendency for the fibrous tissue to form, and that's the stage where there will be atheroma. The clinical symptoms will be quite prominent. Then gradually it results in a deposition of the fibrous tissue. The atheroma becomes fibrous. The fat tissue is replaced by the fibrous tissue, where the artery becomes more inelastic, as well as the lumen is narrow, so the symptoms will become more prominent, and when you palpate, the whole vessels become cord-like. The complicated is when these atheroma plaques are hardened, and they may even get displaced, and when it is displaced, it may produce a blockade to the circulation, and hence it can result in a complication of thrombosis or hematoma. Till this stage of atheroma, the condition is clinically silent. Later on, the symptoms tend to occur as such. That's the typical presentation as such. Now, the atherosclerotic lesions, again, they are classified based upon the same issue I have discussed, same, but how the complications would occur. Initial xanthoma, it may not produce any clinical symptoms, but a fibrous cap of the atheroma which we have shown here, this portion, when it becomes either inflamed or it is comparatively thinner, it may get displaced, or it may result in either erosion of the vessels, or it may get displaced, rupture and get displaced, or it may become calcified. Now, when it is displaced and it results in a sudden movement of the vessel into, or sudden movement of the atheroma into a vital blood vessel, it can result in sudden death, whereas a thrombosis, which may have a rupture and necrosis, healing and so on, there could be repeated courses of that, where the patient may have progressive step by step increasing in the ischemic symptoms, whereas a sudden displacement of this plaque and producing an obstruction, particularly in the coronary area, may produce a sudden death as such. The known causes of atherosclerosis, one of the most important now, earlier it was considered like hyperlipidemia was considered to be the more common causes, but now it's identified as genetic factors. A specific gene now is identified. So genetic factors are now known to be identified as the most important prevalent causes. So genes now are identified. Family history also is well known. Hyperlipidemia, that abnormal lipid level, is considered to be one of the most important cause for the atherosclerosis. So we will discuss a bit more about the hyperlipidemia, slightly bit more, the history as such. Then the diabetes mellitus, cigarette smoking. Now hypertension is also a cause for the atherosclerosis, as well as is a consequence of the atherosclerosis. Patients of hypertension, they are more prone to develop atherosclerosis because of that increased circulatory pressure. The tunica intima cells would be affected, they will be under stress, and that stress itself may produce the damage, and then it can induce the degenerative changes. Or it could be like atheroma may be the initial condition, which may result in the atherosclerosis later. Dietary deficiencies also now are known, particularly junk food, where antioxidants are lesser, and it becomes an oxidant influx. That also is now known to be causes as such. In general, the aorta, the thickest vessel, is the most initially affected as such. Then the carotid arteries are next to be affected. Coronary arteries, iliofemoral arteries are generally, if you look at the statistical incidences of the atherosclerosis, aorta is most commonly involved, and because it is a very thick artery, the clinical symptoms would be occurring much later. Initially, the clinical symptoms will be lesser. Whereas when it comes to the carotid arteries, the clinical symptoms tend to occur quite early, or coronary arteries also, the clinical symptoms tend to occur quite early because it produces blood supply to the vital areas like brain or the heart. So clinical symptoms will be quite prominent. Whereas iliofemoral arteries, when they are involved, the clinical symptoms may get earlier, but the symptoms may not be very severe. It may present as a simple peripheral ischemic condition, and hence the clinical presentation of atherosclerosis can be quite varying. The hypothesis why the atherosclerosis would occur, again, there are many hypotheses now, and uh, these hypotheses again are of different types of hypotheses, like incrustation hypothesis, insulation hypothesis, or monoclonal hypothesis, or response to injury hypothesis. But currently the most valid, the most accepted is the response to injury hypothesis. When there is an endothelial injury, that endothelial injury may trigger the changes of degenerative changes, and that is the most valid and most accepted hypothesis. The other hypothesis, like the thrombus, a clot which is formed within, may result in a degeneration of the intima, or insulation is there are the cells of tunica intima, they tend to grow abnormally, and they may result in accumulation of the lipids and the proteins over there. Monoclonal theory is again there is abnormal cell produced, which is from the time of the progression of the division, it may be produced as such. The response to injury is the most widely accepted explanation of the atherogenesis now. And endothelial injury causes vascular inflammation, and a fibroproliferative response ensues. And probably the causes of endothelial injury include oxidized low density lipoproteins, LDL, cholesterol, infectious agents, toxins, including the byproducts of cigarette smoking, hyperglycemia, and hyperhomocystinemia, such biochemical changes in the body. They may be triggering that injury to the endothelial tissue, and hence response to injury theory is the most widely accepted theory. Now, the oxidized low density lipid is one of the important issue which we have to consider as the common causes. As per the statistics now, with the resource here I have mentioned the source. The atherosclerosis condition begins in childhood with the development of the fatty streaks, where the symptoms may not be seen as such, and these lesions could be found in aorta shortly after birth and appear to be increasing in numbers in persons aged 8 to 18 years. Now, this is something which is somewhat a new information. Earlier, having a thought of atherosclerosis in pediatric conditions was very rare, almost not identified. But these days it is identified, and the theory it's known to be due to genetic factors, and advanced lesions may develop in individuals at the age of approximately 25 years. Till the age of 25 years it may remain silent, and such patients are now well reported. Signs and symptoms of non-coronary atherosclerosis may vary depending upon the organ or the system which is involved. So, atherosclerosis of which vessel, that decides about the clinical symptoms. Central nervous system, mainly carotid artery and its branches, when they are involved, it may present with the symptoms of stroke or ischemic neurological deficit or transient ischemic attack, depending upon the amount of the impact on the blood flow. When the peripheral vascular system is involved, it may present with intermittent claudication or impotency or non-healing ulceration, as we have discussed with the peripheral vascular disorders earlier. In the previous session, we have discussed about. When the GIT vessels are involved, the patient may have present with the mesenteric angina, that's acute pain in the mesenteric vessels, with the epigastric or umbilical pain, absent food, and even may present with the hematemesis or stools with the hematochezia, where the bile may be blood mixed, or even melena or diarrhea also can occur. Patient may have nutritional deficiency also. Abdominal aortic aneurysm may occur in such conditions, which may be asymptomatic or pulsatile till there is a rupture, acute rupture. Then, or there could be target organ failure, like kidney failure also can occur if the vessels are involved. Now, among the causes as such, the hyperlipidemia is supposed to be one of the most common cause as such. So we go into that hyperlipidemia bit in detail. Examination findings of non-coronary atherosclerosis are highly variable but may provide objective evidence of extracellular deposition. That's the important issue. There could be evidence of stenosis or dilation of the large muscular arteries, like aorta or carotid areas, and the target organ ischemia or infarction. And the most other common causes, they are common features which we identify in a patient of non-coronary atherosclerosis is hyperlipidemia presented with xanthelasma or tendon xanthomata. I will show you like what is xanthelasma. It's a sign of hyperlipidemia. Or cerebrovascular diseases like the carotid pulses may be reduced, or carotid artery may show bruise, murmur like sounds could be heard, or neurological deficit could occur. Peripheral vascular disorders, decreased peripheral pulses, peripheral arterial grooves, maybe the clinical signs or cyanosis or gangrene can occur. Aortic aneurysm, pulsatile abdominal mass, and or peripheral embolism could occur. Atheroembolism, where there could be a sudden development of ischemic areas or hyperemia followed by ischemic changes. That is livedo reticularis is a spot of reddish color which may become blackish or bluish or blackish in due course of time. Gangrene may occur, cyanosis, ulcerations could occur, necrosis of the fingers could occur, bleeding from the gastrointestinal tract. So the clinical symptoms could be quite wide-varying. Now, xanthelasma is a clinical sign of hyperlipidemia. Hyperlipidemia is one of the important issue. Xanthelasma is due to the deposition of abnormal fat around the orbits. There will be a typical presentation which is often seen in patients of abnormal lipid metabolism, or tendon xanthomata is the deposition of fat around the Achilles tendon which may present, or there could be nodules, fatty nodules at the hands too. These are all the evident clinical sign of hyperlipidemia, abnormal lipid contents. Now when I go into that abnormal lipid contents, lipid word doesn't mean simply a single fat content, fat as such. Lipid in word suggests about a huge number of molecules which have a triglyceride structure, and the source of that could be either exogenous or endogenous. A dense lipid, a good amount of huge amount of lipid is from the dietary fat, of course, but it's not the fat alone. Consumed fat alone is not the issue. The fat which is consumed would be converted into chylomicrons in the vessel, gastrointestinal tract, and then absorbed into the capillaries, and then it will reach to the liver, and in the liver it will be converted into triglycerides, and these triglycerides would be the main source of all that requirement of the lipid in the body. And there are huge number of molecules of these lipids, and hence they are categorized into LDL, low density lipids, and very low density lipids or high density lipids depending upon the molecular structure, which may be reaching to the peripheral tissues to meet their requirement. And when there is a more of that low density lipid would have a lesser solubility, it may get deposited. Of course, that excess of fat substances would be, or as well as the end metabolic products, they will be converted into cholesterol, and the cholesterol would be excreted by the liver. Now, the same whatever I have discussed earlier, to make it more picture-like, the initial fat molecules are quite big, chylomicrons, and gradually as you go into these, the molecular size becomes lesser. As the molecular size becomes lesser, the density also would be lesser. High density lipid would have a smaller molecular size, and hence it can easily pass through and get somewhat soluble, and hence doesn't get deposited. It also has a property of making these low density lipids soluble, and hence it's categorized as good cholesterol, whereas the low density lipids are considered as bad cholesterol because they have a higher chance of getting deposited as such. Though the cholesterol and the lipids, they can be assessed biochemically in the laboratory, even from a simple gross identification of the serum, if you just separate the serum and look at the serum would be very transparent when the triglyceride level would be normal. But as the triglyceride level becomes increased, the serum becomes more and more turbid. So this also can be a simple test. Biochemical test of assessing that low density and high density lipid is one part as such. When you go for a lipid profile examination, the results which you get would be like cholesterol, triglycerides, high density cholesterols or high density lipids, LDL, low density lipids, or ratio of cholesterol to high density or low density to high density ratio. Now, the normal levels are considered to be 200 milligram of cholesterol, triglycerides 150, high density lipid 60, and LDL in between 60 to 130. And the ideal ratio of high density to the low density lipid cholesterol is 4.0. Now, when this ratio increases into 5 to 6, the risks are more. So that's the usual normal ranges which are seen in patients of in our routine conditions. These days, this lipid profile examination has become a fashion, and even a slight modification, changes in this level are considered to be pathological. The causes for that abnormal lipid levels or abnormal lipid level, hyperlipidemia, could be of different causes, and hence their causes are now categorized into type 1, type 2A, type 2B, type 3 or type 5 as such, type 4 and type 5. It is considered to be either familial lipoprotein lipase deficiency, which is rare as such, and the plasma lipoprotein, is mainly the chylomicron itself would be presented in the plasma, which is a very rare condition where the fat would not be digested properly, and improperly digested fat will be entering into circulation. The familial hypercholesterolemia is another of the condition where there is known to be genetic factors, and comparatively it's less common, and where the patient may have a high LDL level, the other fat level may be normal. Then polygenic hypercholesterolemia, which is the most common, where there could be causes are mainly dietary factors as well as genetic factors. Mainly it's related to the diet and exercise, the polygenic hypercholesterolemia, and there again the LDL will be raised as such. Then familial beta lipoproteinemia, where there will be lesser lipoproteinemia as such, which also is a genetic condition, and in that condition it's a rare condition and it's produced due to genetic factors, and the level would be LDL as well as chylomicron would be increased. Then hyperglyceridemia also is another hypertriglyceridemia is a more common condition among the Indian population. Among our patients, majority of the patients are of this category, and where the diet is the most important, diet and lifestyle is the most important cause, as well as there could be genetic tendency, and in these patients VLDL level will be very high as such. Then familial combined hyperlipidemia is another of the condition which is comparatively rare, where VLDL as such, LDL will be raised as such. Now, as far as the information about these lipid abnormalities and their consequences of the body, there is a lot of changes in the approach as such. The information consequences of the hyperlipidemia and the prescription of the drugs also is changing. A lot of fashionable drugs are added, and many times unnecessary drugs are being given. Drugs have a limitation for that. Now, there is a huge change every few years, every 10 to 15 years. There has been a very rapid change in that prescription. Starting from 1950, it was like the cholesterol was considered to be one of the causes for coronary vascular disorders, and the need for reduction was considered. WHO made a cooperative study with the clofibrates earlier in 1965, and up to around 1980. Clofibrate was the first drug of choice, and clofibrate was used quite frequently in these conditions. But later on, gradually there was a shift to the statins. Now, these days, statins are more prescribed and quite frequently prescribed. From 1980 onwards, the statins are prescribed, and now it is the statins which is considered to be the ultimate drug and quite commonly prescribed among the practitioners. And today, when we see the patients, majority of more than 50% of the patients would be having statin as a prescription unnecessarily. See, the issue is that majority of the abnormal lipid levels in our patients is purely due to the diet. If you maintain that dietary factors as well as exercise factors, a good number of patients' lipid levels can be maintained normally. Whereas administration of the statins would be maybe to a certain extent reduce the levels, cholesterol levels, but it can produce more complications. The one of the most common complication is the pain in the joints, vitamin D deficiency consequences would occur, and that itself would be leading the patients to Ayurvedic prescriptions. So that's a very common complication as it which is seen. And majority of the patients who present with that vague pain in the muscles, which are not confirmatory of an osteoarthritis or other myalgia, they could be due to the statins, and in such conditions, Kaishwaragugula and Mrityunjay is the best drug which can reduce the symptoms. Anyway, there are lots of newer molecules of the statins. Virtually there is not much of a difference between these individual molecules. The only issue is newer molecules, they will be charging more, they will be more costly. Otherwise, the primary basic statin like lovastatin could be enough to manage. These days you will have newer statins, every year there are some new molecules added. In addition to these statins, the other drugs which are often used are fibric acid derivatives like fenofibrate and bile acid sequestrants, which help in excretion of the cholesterol in larger quantities, are cholestyramine. Of course, cholestyramine would be definitely more useful than the statins as I have seen. Or the another fashion which has now become is omega-3 unsaturated fatty acids are given as such. That's one of the issue. Now, as far as the statin use is concerned, earlier it was claimed that statins will definitely reverse the atherosclerosis. But a huge number of studies now have come up where the atherosclerosis is not cannot be reversed, or that claim of reversal of the atherosclerosis is a questionable now, based upon the reference. I have put that reference on study of large number of patients, and particularly the statins and silostazol, the role of them in preventing atherosclerosis is questionable. Now, as far as the statin therapy is concerned, now the present days approach of the statin therapy is having either high intensity statin therapy or moderate intensity therapy, low intensity therapy. Ideally, low intensity therapy is to be advised in patients who have just the LDL level being raised but no other symptoms. High intensity is usually prescribed in patients who are having the other risk factors like diabetes or hypertension. That is the standard method. And the doses of these statins in the low intensity therapy is a low dose like simvastatin 10 mg or atorvastatin. Atorvastatin is generally not prescribed in the low intensity therapy to prevent this. But unfortunately, what happens is if you look at the prescriptions given in the current patients, in patients who come to you, almost every patient is given high intensity therapy, high doses are given, and these high doses of statins, particularly atorvastatin, like 40 to 80 mg per day, which is a very frequent dose which is prescribed now in majority of the patients, it can result in more complications as such. The complications of what I told as the muscle pain, rhabdomyolysis complications, they tend to occur quite frequently, and that itself makes the patient more maybe feel disease than the other way. Whereas this kind of a protocol of low, moderate and high intensities are not really followed in the routine clinical practice among our conditions. Anyway, that's about the important medical treatment. Now, as far as as I told you, the prevention of hyperlipidemia can be better managed with the non-pharmacological interventions where patients may have either elevated blood pressure or who need antihypertensive agents as such. Antihypertensive drug may be required. Along with that, a protocol for weight loss, a healthy dietary pattern where more vegetables are given, less spicy food is given, the consumption of the sodium is reduced, and potassium supplementation is also considered one of the issues. Increase physical activity or structured exercise program, limited or no alcohol would be the other advice. As far as other Ayurvedic medicine are concerned, I would be prescribing Kanchanala Gugulu Arogyavadini Kumaryasava as a target for the hyperlipidemia. Vivetana or Manjashari Ksharabasti, depending upon patients, is a game changer. It can produce a significant change in the outcome of hyperlipidemia conditions. That's about the hyperlipidemia and atherosclerosis. The next part we discuss about the other hypercoagulability conditions and other diseases which could be related to the blood supply as Raktavaha Sotodrushti. So with this we conclude today. If there are any questions, we will try to answer, and then there are no questions.